Okay, so this slide might be a bit repetitive, but I think this is an important topic to discuss. So, hyperadrenalism. So, too much hormones being secreted by the adrenal gland. Okay, and in particular, we're going to talk about the adrenal cortex because the adrenal medulla is really just has to do with the catecholamines being secreted, such as epinephrine, norepinephrine, and dopamine. Okay, so what's going to happen with too much adrenal cortex hormones being secreted into the bloodstream? And we'll concentrate on cortisol first. Okay, so when you have too much cortisol, well, you're going to be hungry. It stimulates appetite. And you're going to gain weight. Okay, so cortisol is a stress hormone. Um, it's going to activate appetite again, to which is going to lead to weight gain. Redistribution of body fat to the face, the trunk, and the abdomen. So these patients typically have relatively thin arms and thin legs, and they have more central obesity. So they'll have a moon face, they'll have a buffalo hump, and that's fat redistribution on the lower part of the back of their neck, and they'll have central abdominal obesity. Okay. Um, so let's look at some other ones. Increase in the waist to hip circumference ratio. Okay, so that just means that their abdominal girth, so the size of their abdomen, is much, much bigger because they're becoming obese than the circumference around their hips. Okay, the purple striae that we see on people's legs and their abdomens, that's from excessive cortisol. Easily bruising, thin skin, and poor wound healing. While cortisol definitely thins the skin, it leads to bruising under the skin, and because it has immunosuppressive and anti-inflammatory effects, it's going to reduce wound healing. Okay. What else is going to happen? Well, women can develop facial hair. Okay, so remember that the adrenal cortex actually secretes some androgens, and androgens in women, or excessive androgens in women, will lead to some facial hair, male pattern hair growth, right? Again, because of those excessive androgens, and amenorrhea, so loss of periods. Why? Because there's more circulating androgens. Now, often in this condition, you also get excessive release of aldosterone because aldosterone is made in the adrenal cortex. And that's going to lead to reabsorption of sodium, which is going to reabsorb water, and that will lead to peripheral edema, right? And an increasing plasma volume. So they'll be hypervolemic. Okay? So remember, this can also occur, or a lot of these symptoms can occur when we administer um, uh, corticosteroids for treatments of other conditions. So when we give someone prednisone or dexamethasone, they're going to gain weight. They're going to have excessive hunger. And over time, they're going to get a moon face, buffalo hump, thin skin, bruising of the skin. It leads to osteoporosis because it causes bone breakdown, the cortisol does. They're going to get those striae on their abdomen and legs. Now, they won't necessarily get the hirsutism and the male pattern baldness because we're not giving them androgens, right? And they won't get the aldosterone effects because we're not giving them aldosterone. So think of the adrenal cortex as if it's excessively producing hormones. It's going to be cortisol, aldosterone, and androgens, okay, from the adrenal gland. Okay, so let's look at another condition called Addison's disease. And that's basically adrenal gland failure, or in particular, adrenal cortex gland failure. Okay, so it's the opposite of Cushing's, and it's far less common because, as I've mentioned multiple times, Cushing's syndrome is typically caused by administration of corticosteroids to patients. Okay, so Addison's disease is definitely not as common. And what it means is that you have adrenal glands that have failed. It's an autoimmune disease, and there's a deficiency in cortisol and often aldosterone secretion by the adrenal gland. Okay? And usually, most of the adrenal cortex has to be destroyed before the symptoms become noticeable. So if you think of almost any organ in our body, we have a lot of reserve in our organs. So for example, we can easily survive with one kidney. We can easily survive with one healthy lung. Okay? So the adrenal glands are the same. They can easily perform their function until a critical percentage of the gland is destroyed. Okay, and typically it's a high percentage. If you look at the adrenal cortex, 90% of it has to be destroyed before it just can't maintain proper levels of cortisol, aldosterone, and some estrogens and androgens that are produced in the adrenal cortex. Okay, and what happens in Addison's disease is you can develop an Addisonian crisis, where there are severely diminished cortisol levels in the bloodstream. And typically aldosterone levels are reduced as well. So it's going to lead to hypotension. Remember, cortisol is a stress hormone. So lack of cortisol will lead to hypotension. Hypoglycemia. Cortisol was responsible for helping release glucose from the liver. So if you have a lack of cortisol, it can lead to hypoglycemia. Okay, and weakness because you're hypotensive. You don't have your normal circulating stress hormone. Okay, in actual fact, a lot of patients with Addison's disease come in with gastrointestinal symptoms. So nausea, vomiting, weakness, hypotension. And because they're not secreting aldosterone, they can come in with hyperkalemia and hyponatremia, right? The sodium's not being reabsorbed and the potassium's not being secreted. So that can be a tip-off for us that, oh, this could be Addison's disease. Their sodium is low in their blood and their potassium is high in their blood. Okay. So this can happen from adrenal failure, or it can happen from us stopping a steroid medication abruptly after someone has been taking it for weeks to months. So let me give you an example. Someone has been taking prednisone for 5 days and they stop it. That's not a problem. Okay. Compared to someone who's been taking cortisol for 3, 4, 5 weeks or longer for, say, rheumatoid arthritis or some other inflammatory condition, and they abruptly stop it. Okay, well, what happens? Well, they're going to develop an Addisonian crisis. And why is that? Well, the steroid that they were taking was actually having a negative feedback loop to the pituitary gland. It was stopping the pituitary gland from releasing ACTH. So over weeks and weeks, the pituitary gland didn't secrete ACTH, so the adrenal glands were turned off. And now if they stop the steroid abruptly, such as prednisone, well, the pituitary gland hasn't had time to wake back up and get activated to stimulate cortisol secretion by the adrenal gland. So that can develop in a deficiency in cortisol levels in the bloodstream and an Addisonian crisis. So if someone's been on prednisone or dexamethasone for weeks and weeks, we always slowly taper them off the medication. And that allows ACTH to start to be secreted by the pituitary gland and to start stimulating the adrenal gland to make its own cortisol. Okay? So if someone asks you, should I stop my cortisol that I've been taking for the past 2 months for my rheumatoid arthritis? Should I just stop it one day? Absolutely not. They would go into an Addisonian crisis and start vomiting, nausea, hypotension, hyponatremia, hyperkalemia. Okay? So we taper people off of long-term cortisol use to avoid an Addisonian crisis. Okay, so let's look at adrenal failure a bit more closely. Okay, so adrenal failure is called Addison's disease. And what is it? It's a loss of cortisol secretion by the adrenal gland, and also aldosterone can be reduced. Okay, so primary Addison's disease is caused by the adrenal gland being ineffective and diseased. Okay, that autoimmune disease that we spoke about. So whenever we use the word primary, so primary Addisons, for example, we're talking about the organ itself that's now not functional. And this is leading to a reduced cortisol level. What about secondary Addison's disease? Well, this is caused by the fact that ACTH is now not being secreted into the bloodstream because there's something wrong with the pituitary, and that's leading to secondary Addison's disease or secondary adrenal failure. Okay? It still leads to the same problem. It's just where did the problem originate from? Will determine whether we call it primary or secondary. Okay? So let's look at the symptoms on the right here of Addison's disease. Deficient cortisol and often deficient mineralocorticoids such as aldosterone. Okay, hypoglycemia we spoke about already. The fact that there's less glucose being secreted by the liver into the bloodstream. Hypotension. Yes, cortisol is a stress hormone. It maintains blood pressure. And also, if you're not producing aldosterone, that's going to have a diuretic effect. You're going to lose sodium, you're going to lose fluid, and you're going to keep your potassium. You could be hyperkalemic. Okay? Gastrointestinal symptoms are really common in Addison's disease. I mentioned they typically come in nauseated and vomiting because of the lack of cortisol having its effect on the gastrointestinal tract. Okay? Changes in the distribution of body hair. Well, remember, you have estrogen and you have androgens that are produced in the adrenal cortex. So if they're deficient, that can alter the sex hormones in your bloodstream, such as estrogen and androgens, and that can alter body hair distribution. Okay. Bronze pigmentation of the skin. Okay, this one's interesting. So if you have Addison's disease from adrenal failure, what's the pituitary gland going to do? It's going to secrete incredible amounts of ACTH to try and force the adrenal gland to work. And what does ACTH do in addition to stimulating the adrenal cortex? It can cause pigmentation of the skin. Okay, so it can stimulate the melanocytes to increase pigmentation, and you get this bronze appearance in Addison's disease. Okay. Let's just look at the bottom, an adrenal crisis. So an adrenal crisis is really profound reduction in circulating cortisol and the aldosterone. Okay, that's it. That's the only difference. You've gone into an adrenal complete failure. So profound fatigue. You're typically vomiting and nauseated. Hypotensive. You'd be hypoglycemic. Your sodium would be low in your bloodstream because you're missing aldosterone, and your potassium would be high in your bloodstream because the aldosterone is missing. Okay? Okay, so hypoadrenalism and glucocorticoids. And this is an important concept, and I know I've mentioned it somewhere else. But so when we just looked at a condition called Addison's disease, which is a autoimmune disease that destroys the adrenal cortex. And you can have low levels of cortisol, low levels of aldosterone, and lower levels of androgens. But the most important ones are the deficient cortisol and the deficient aldosterone in the bloodstream. Okay, what about glucocorticoids? Well, when we give glucocorticoids for many conditions, such as rheumatoid arthritis, lupus, ulcerative colitis, Crohn's disease, asthma flare-ups, COPD flare-ups, there's so many conditions where patients are taking exogenous corticosteroids, such as prednisone and dexamethasone. Well, if they take them typically for weeks to months, okay, it's not for a week. A week is not a problem. Patients can just stop glucocorticoids abruptly if they've just taken it for a week. There's been no problem. But when you take them for longer periods of time, such as 3, 4, 5 weeks or longer, well, those glucocorticoids are having a negative feedback loop to the hypothalamus and the pituitary gland and turning them off. Telling the hypothalamus and the pituitary gland, I have enough circulating glucocorticoids. That's the negative feedback loop. Okay? So here's this patient that's been taking glucocorticoids for months, and they weren't told to slowly go off the glucocorticoids. They just suddenly abruptly stopped them. Well, what's going to happen? Suddenly, the glucocorticoids in the bloodstream are going to go to a very low level because the patient's not taking them anymore. The pituitary gland and the hypothalamus haven't been reactivated. They haven't woken up again to start secreting ACTH back into the bloodstream to stimulate the adrenal gland. So this patient is going to be deficient of glucocorticoids, i.e. in the body, cortisol, because there's no secretion from the adrenal cortex. And they're going to go into an Addisonian crisis. So they're going to have all the symptoms of a patient with Addison's disease because there's no circulating cortisol. Okay? So stopping steroids abruptly when they've been used for weeks to months is never done. Okay, we always have patients taper the steroids slowly downwards so that the hypothalamus and the pituitary gland can start secreting ACTH from the anterior pituitary to then start stimulating the adrenal gland to produce cortisol again. Okay, so I hope that makes sense. So remember, suddenly stopping a glucocorticoid after having taken it for months will lead to an Addison's crisis. So make sure you understand that concept. Okay, so I'm going to go through the symptoms of adrenal insufficiency again. Yes, it's a repetition, but I always find repetition is a good thing. Okay, because it allows you to listen to it again and absorb some extra information or just reinforce the information that you already have. Okay, so let's say that a patient develops Addison's disease. Okay, so they have sudden loss of cortisol, sudden loss of aldosterone secretion from the adrenal cortex. Okay, cortisol is a stress hormone. It's required for maintenance of metabolic functions in the body and maintenance of a normal blood pressure. Okay, so let's see what symptoms are going to develop. So patients will come in with profound weakness. They'll come in with hypotension. They'll be fatigued, which is basically the same as weakness. They'll be anorexic, okay, because cortisol stimulates appetite, right? So lack of cortisol, they're going to be anorexic. And even more importantly, they usually come in nauseated and vomiting on top of the anorexia. They may be hypoglycemic because they're lacking cortisol, which usually helps break down glycogen to glucose. So now there's a potential to be hypoglycemic since they're missing the cortisol in their bloodstream. What about the electrolytes? Well, these have more to do with the lack of aldosterone. So if you don't have aldosterone, you can't reabsorb sodium. So you're going to develop hyponatremia in your bloodstream. If you don't have aldosterone, you can't excrete potassium into the urine. So they're going to be hyperkalemic. Okay. What about the tanned appearance? Well, when the adrenal glands fail, the pituitary gland starts to increase more and more ACTH secretion, right? Because it wants the adrenal gland to produce that cortisol, but the adrenal gland is unable to produce the cortisol. So there's high levels of circulating ACTH, which is very similar to melanocyte stimulating hormone. They have similarities in their molecule. So since melanocyte stimulating hormone stimulates the melanocytes and causes a tanned appearance, excessive ACTH in the setting of Addison's disease will also lead to a bronze appearance of the skin. Okay, so understand that concept about why they get this bronze appearance. It's because of all this ACTH that's now being produced from the anterior pituitary. So if I think of someone with Addison's disease, I immediately think, okay, they're lacking cortisol, they're lacking aldosterone. Okay, they're going to be weak because of deficient cortisol. They're going to be hypotensive because of the lack of cortisol in their bloodstream. They're going to be nauseated, vomiting, anorexic, because cortisol is involved in the digestive system and now it's lacking. They could be hypoglycemic because there's no cortisol to help break down the glycogen. The electrolyte disturbances are all about the lacking aldosterone. Okay, and I'm sure you can figure out the hyponatremia and the hyperkalemia because of the lack of aldosterone. They're going to have a tanned appearance because of excessive ACTH secretion from the anterior pituitary. Okay, I hope that helps. Okay, just briefly here, how can we find out if someone has adrenal insufficiency, meaning their adrenal glands have failed? Well, we can inject them with ACTH. We can do an ACTH test. And what we do is after we've injected them with ACTH, we do cortisol levels in the bloodstream. And ACTH should go to the adrenal gland and stimulate cortisol secretion. But in a patient with adrenal insufficiency, meaning Addison's disease, they don't make the cortisol. So the ACTH is not going to cause a rise in cortisol in the bloodstream, and that will help with the diagnosis of Addison's disease. Okay? How do we treat Addison's disease? Well, remember, they need the glucocorticoids in their bloodstream, and they need the mineralocorticoid, which is the aldosterone. So they're going to get a prescription for cortisol. Okay, that's a glucocorticoid, and they're going to get a prescription for a type of mineralocorticoid that will behave the same as aldosterone. Okay, so they get both the glucocorticoid and the mineralocorticoid. Okay. Now, an important detail to remember about Addison's disease is that so these patients are now having to take glucocorticoids and mineralocorticoids. Okay. Now, if they have a major stress, such as surgery, trauma, well, remember, cortisol is a stress hormone. So the dose that they're taking as a pill may not be enough, right? Because usually the adrenal gland would be able to increase cortisol levels under stressful conditions. So if we know a patient is having to go for surgery, or if they've been in trauma and we know they have Addison's disease, we very likely will have to increase their glucocorticoid doses to accommodate for the recent stress. Okay, we won't spend too much time on this one, but believe it or not, you can have a tumor that causes excessive aldosterone secretion from the adrenal cortex, and that's called Conn syndrome or hyperaldosteronism. Okay, so what's going to happen with too much aldosterone secretion from an adrenal tumor? Again, this is relatively uncommon by itself. It's usually in combination with a tumor that's secreting cortisol and aldosterone. Okay, but let's just look at this one just so that we understand what's happening. So if you have too much aldosterone, you reabsorb sodium, and you reabsorb fluid from the kidneys. And it causes increased potassium losses because there's too much aldosterone. Okay, well, too much sodium reabsorption and fluid reabsorption leads to hypertension and also hypokalemia. So let me give you an example. If someone comes in and they're hypertensive and we give them medications to reduce their blood pressure, and they come in over and over many months, and we just can't control their blood pressure, and we notice that their potassium is low, we might suspect Conn syndrome or hyperaldosteronism. So this is a cause of secondary hypertension. Okay. So most causes of hypertension we call primary hypertension. There is no known cause, and that's about 95% of patients with high blood pressure. A small percentage of people have hypertension from another cause, and this is one of them, hyperaldosteronism. Okay? In fact, Cushing's disease is another secondary cause of hypertension, right? Too much circulating cortisol leads to hypertension. So if someone has resistant hypertension, we might check their aldosterone levels, we might check their cortisol levels to see if they have a secondary cause. Okay, so let's just talk briefly about this benign tumor of the adrenal medulla called a pheochromocytoma. Okay, so it's a pretty uncommon tumor, but it develops in the adrenal medulla, leading to high epinephrine and norepinephrine levels in the plasma. Okay, well, you can imagine what very high levels of epinephrine and norepinephrine will do in the circulating bloodstream. It's basically like activating the sympathetic system over and over again, but inappropriately. Okay, so every once in a while, this tumor will secrete excessive amounts of epinephrine and norepinephrine into the bloodstream. So how do patients present? Well, they present with high blood pressure, headaches, excessive sweating, palpitations, their heart is racing, tremors, panic attacks. They can present with flushing, all kinds of symptoms when excessive amounts of catecholamines, meaning epinephrine and norepinephrine, are suddenly secreted into the bloodstream from this tumor. Okay? So it's not a very common tumor, but you can imagine that a lot of these symptoms are relatively common in patients. So hypertension, sweating, headaches, anxiety. So it takes a bit of thought to consider this particular tumor as the cause of someone's symptoms. Okay? And by the way, this is another cause of secondary hypertension. So we spoke about Cushing's disease causing a secondary hypertension. We spoke about Conn's disease, which is hyperaldosteronism. Now we have a third one. A pheochromocytoma can be a secondary cause of hypertension. Remember, 95% of patients with hypertension, we don't even look for a secondary cause. They have what's called essential hypertension.